This is a video on bone tumors. So it's chapter 16 in your textbook, page 616. So it's actually tumors of the musculoskeletal system. There are a number of different types of tumors, and they all reflect the different types of cells that are involved in bone. There's osteoblasts, osteoclasts, there are bone marrow cells, there are cartilage cells, and these are all primary tumors. By primary tumors, it means they're not caused by something else. Um, a lot of metastasis actually happens to bone. So probably the vast majority of bone cancers, the people that have bone cancer, actually have metastasis from someplace else, like prostate or breast or liver or something like that, because they all metastasize to bone. So these are some of the primary neoplasms that happen. Now, a couple of um, kind of background things is, and we talked about it before when we talked oncology, is that there are benign neoplasms and there are malignant neoplasms. And the benign tumors are all well differentiated. There is a very marked difference between the healthy tissue and the cancerous tissue. The uh, the the cells themselves resemble normal tissue. Uh, these things don't invade, uh, except maybe locally. Uh, they don't really have autonomous growth. They don't metastasize, uh, but they're there, and they are tumors. They're neoplasia. Now, the word benign means that they're not going to metastasize, but that doesn't mean that they're innocuous, that they don't give any problems. Uh, a lot of things, a lot of these benign tumors take up a lot of space. They may push on nerves. They may cause um, pathological fractures. They may cause other complications. So some benign tumors will actually morph into malignant tumors as well, especially the cartilage ones, it seems. Um, but they can impair blood supply, they can compress nerves, all of that stuff. So they definitely are not innocuous. They can cause lots of serious problems, but metastasis isn't one of them. The malignant tumors, the primary tumors, really have the capacity to spread to other sites, and they're often really quite aggressive. Um, they they go to lungs through the bloodstream. That's a common thing, but they're not very common. Um, they don't really know what caused most of these things, but uh, maybe by the time that you're finished with your careers, they will know more. So this is a list, and I want to kind of explain that the names of these things, while they all sound very similar, all have essential meaning. So osteo means it has to do with bone. So osteoid is the fibrous, the protein part of bone that's laid down by osteoblasts. Uh, Oma means tumor. A sarcoma is a malignant tumor. If it's just oma, it's probably benign. So when we look at something like osteoid osteoma, that means it's a benign bone tumor, osteoma, primarily made up of osteoid. so unmineralized bone. Osteoblastoma is a tumor, a benign tumor that comes from osteoblasts. Osteosarcoma is uh, is a malignant tumor, probably coming from osteoblasts or osteocytes at least. Chondrosarcoma is a malignant tumor of chondrocytes, of cartilage cells. Uh, when we get to Ewing sarcoma, a giant cell tumor, the giant cell tumor is actually also called an osteoclastoma, so that, that would indicate that it's from osteoclasts. Myel, M-Y-E-L, uh, means marrow. So a myeloma is a bone marrow tumor. And this obviously happens in multiple sites. Chondroma, cartilage tumor. Enchondroma, a cartilage tumor inside the bone. Osteochondroma is a benign tumor that's made up of both bone and cartilage. It says it right in the name. So that hopefully that helps keep these things straight. So we'll start with the first one, the osteoid osteoma. And really, it's a benign tumor of immature bone. It's made up of osteoid. It this osteoid gets laid down fairly randomly, inappropriately, and doesn't ossify. It's found inside the bone. It can be found in any bones, but not in the skull. They don't get it in the skull because the skull, being intramembranous, is a slightly different physiology, so it doesn't normally happen there. It causes some dull, achy pain, especially if it's taking up space or causing a weak spot in the bone. The bone may react as a weakness. These lesions are very small. To be an osteoid osteoma, it's a small lesion. Now, there may be multiples or they may be single, but they're very small. And because there's no hydroxyapatite, there's no calcification of it, it looks lighter under X-ray than regular bone. So this, where this yellow arrow is over here, is pointing at an osteoid osteoma. When we look at this, it's very easy to miss, especially if it's in the pelvis, because quite frankly, gas in the intestines kind of make that radiolucent look. And if the intestines are overlaying the pelvis, it looks like that. I had an X-ray prof that used to call them PFs, potential farts. Now, this X-ray came from this website, tumoursurgery.org, and there's more information there on this particular thing. Now, the website, and you'll see that I've used this website a fair amount for this series of slides, is really a blog done by an orthopedic surgeon that specializes in bone tumors, especially sarcomas, doing surgery on them. So it's kind of a patient information thing. So that's an osteoid osteoma. Now, an osteoblastoma is pretty much the same thing. They're very similar, but they're larger and they expand. Like they will get a lot bigger. Normally we see them in younger men under the age of 30. Don't know why. Probably it's got something to do with testosterone, but I haven't read an adequate explanation of why it's in men. They take up a lot of space and they cause weakness in the bone. Because it's not mineralized, so the bone flexes at that point. When the bone flexes, it causes nerve endings in the periosteum to really react. So there's a fair amount of pain with these ones, and that's usually the presenting complaint. They X-ray it, and you see this big lesion. Now, one of the things that you'll notice in this lesion when you see the this kind of hollowed out radiolucent thing is that it's got really well defined margins. You can really tell what is healthy bone and what is tumor. There's really a sclerotic ring around it, where because the tumor is soft, um, there are stresses placed on the mineralized bone around it, and so, as we know by Wolff's law, the bone grows where there are stresses placed upon it. So you get this kind of white sclerotic margin around the outside of it. It is a benign tumor. What has to happen to get rid of it is they have to do surgery, and what they do is they do curettage. They literally just scrape out all of this abnormal tissue from, and they create a hollow where it is. They take this little metal scraper, and it's like a Halloween pumpkin. You take it down to the the solid, and then what they hope is remodeling will fill back in with normal bone. Again, this is from tumorsurgery.org. Um, if you want to read more, go to that website. That's osteoblastoma. Now, osteosarcoma is an extremely malignant tumor. It's it's very painful. Um, it's based in osteoid, so it is like an osteoblast um, thing. It's normally seen in young men, and when I say young men, I mean young boys, teenagers, prepubescent, even. It seems to be uh, targeting them. Although there are lots of girls that get it too. It's by no means an only seen in boys thing. This is the cancer that Terry Fox had. Now, in this particular picture, in this X-ray that you see there, this is of the proximal end of a humerus, so it's a shoulder joint, and it is really, really moth-eaten. And that's how it's described. It looks like it's just eaten away. Now, one of the things that you can see, because of the rapid growth, and it's really lytic, it's very destructive, the bone is hollowed right out there. And and what I want you to kind of see from this X-ray is right along here. It's not well differentiated. Like you can't tell the mark between what is tumor and what is healthy, unaffected bone. It, it's not clear cut. And that's really a hallmark of any um, malignant sort of thing. Um, for some reason, it seems to grow uh, starting at the growth plate. And so very common in and around the knee, because that's very actively growing in adolescence. And another place is at the proximal end of humerus, at the distal radius, like those places where there are big epiphyseal plates that are undergoing rapid change. And it's probably got something to do with growth hormone and other things that and maybe stresses at that point that actually start this going. Now, this is a very interesting tumor. Uh, it's fatal if it's left untreated. It's often fatal even if it is treated. Um, the pain that they get is really, really bad. And one of the hallmarks of it is that the pain actually wakes people up from sleeping. Now, there's pain that's worse at night that prevents you from going to sleep. But most of the time, when pain prevents you from going to sleep, when you finally do get to sleep, you stay asleep. This will actually wake you up from a deep sleep. The pain gets so bad. The joints or around the site of the lesion gets really swollen and really warm. So there's a lot of inflammation in the soft tissue that surrounds the joint. Now, it's a very rapid onset, and because it happens in adolescence primarily, it's usually confused with a sports injury. Um, it's and it shocks people that it's not, and it masquerades at that. And you got to be very careful as a practitioner because the history will look like a sports injury, and generally speaking, the parents assume that it is. So that's the information they will give you when you're taking a history. So it's like, okay, you know, my son was playing football, hurt his knee, and it's all swollen, but it doesn't seem to be getting any better. It's been 6 weeks, and it's been waking him up at night. And that's when the little hairs on the back of your neck should stand up. It's the waking him up at night. It's the hot, swollen, and that. Um, when I was in, I was newly graduated, my girlfriend, who is a chiropractor as well, the girlfriend du jour, uh, she actually had this young girl come in who was a dancer, and from her mother's dance studio, and it was like, oh, uh, the daughter has hurt her knee, twisted her knee dancing at a dance competition, and it doesn't seem to be getting any better. And Cindy, Dr. Hevner, had some x-rays taken, and what she saw was very similar to this x-ray that you see, except it was at the knee. Uh, and it was actually very traumatic. We were just first year in practice, and it was osteosarcoma, and that girl, I think she was about 13 or 14 at the time, actually had to have her leg amputated for it. That's a common thing. That's the Terry Fox thing. Now, there's a really cool thing that happens, and for some reason it happens more in Canada than any place else. Maybe the surgery was pioneered here, and I actually have a patient that had an osteosarcoma when he was 15, and he had this surgery done. So what they do is they end up having to amputate about midway on the femur. But the tumor is at the knee. So the distal part of the leg is perfectly fine. So what they've started to do is called the tibial turn-up. You can Google that if you want. But what they do is they cut off the tibia. So they peel back the quads and the hamstrings, and they cut off the femur, and then they cut off the tibia below the lesion, and they try and match up for length for the other side, and then they fuse the tibia onto the end of the femur backwards, so that the heel of the foot points forward, and then they hook up the quads tendon to the Achilles tendon, and they hook up the hamstrings to the dorsiflexors, and they literally put a backwards foot on at the knee, and then the prosthetic that they put slips over this foot, and so that gives the kid a functional knee, uh, and it's wild to see, because it's just wild to see. Google it and it'll freak you out. Um, Now, the guy that I know that has it, he's about 30 now, 30, 32 or 33 actually, and he plays hockey. Like, he can skate, and like, when you see him walking, you have no idea that he's got a prosthesis, because the knee, it looks like perfectly like a knee until you see him in shorts or something, and then it's just a very odd thing. Um, Usually, though, an osteosarcoma is has to be completely removed. Now, one of the big problems with it is it metastasizes very readily, usually to lungs, and if it goes to that stage where it metastasizes, prognosis is not good at all. So, a chondrosarcoma is a malignant tumor, um, but it's a slow growing malignant tumor, and it's of cartilage origin. So you see it mostly close to joints, because that's where the cartilage is. They often start out as an enchondroma, or like a benign cartilage tumor, uh, that where the cartilage cells start to invade into where the bone is, and uh, and then it turns malignant. And when it does, it's called an or chondrosarcoma, rather. So it will not present with pain. It won't present with much at first. Later, it does become painful. It's not as aggressive as an osteosarcoma, but it'll still metastasize. When it metastasizes, it goes hematologically, usually to lungs or to bones, sometimes to other organs. And because it is a sarcoma, it has to be removed. And it's more than just the tumor. They usually end up having to take the bone everywhere, the bone that is affected by this tumor. Okay, Ewing sarcoma is slightly different. A Ewing sarcoma is actually from non non-osteogenic sources. It really is from a neuroectoderm, and it it comes from a genetic problem. There's a couple of specific genes get translocated in a very specific way, and it will cause this problem. So it happens in younger kids. They'll see it more in younger kids. But it's one of those things, because it's a genetic problem, it's inevitable. Now, it's not necessarily an inherited problem, it's a congenital genetic problem, and it happens because of this translocation in the parent's genetic material in the gametes. So it's not a mutation, and it's not something that will get necessarily passed down. What happens is this genetic translocation happens because of parental exposure to pesticides or something like that. Um, for some reason, it happens mostly in Caucasians, and it happens in certain occupations. People that farmers seem to get it more because of pesticides. People that use solvents at work. People that are exposed to various other things. And now the parents don't necessarily get sick with it. What happens is they end up with this genetic mistake during meiosis, and it that's the that's the gene that the kids get. Um, Parental smoking will do it as well. Now, when these things start growing, they grow and they grow really fast. And one of the problems is that it outgrows its blood supply. So it's neuroectoderm and it outgrows its blood supply. And when that happens, it ends up dying in the center and bleeds. So they end up with this hemorrhagic necrosis, it's called. And well, they'll turn into hematomas and such. Uh, they can be quite something. Now, the growth is so fast, and it happens in kids, that what happens is that the periosteum starts to lift before before it completely ossifies. And so what ends up happening is the periosteum keeps on lifting, ossifying, lifting, ossifying, lifting, ossifying, and you get what's called an onion skin appearance. And you can see it right along here where this yellow arrow is to the right of this particular femur. Now, you can see that this is a young child. You can see the epiphyseal plate. You can see that the ischium and ilium and pubis are still separate bones. You can see that there's still a separation. There's cartilage in the acetabulum there, and you'll even see that the greater and lesser trochanters aren't very well developed yet in this. They're still primarily cartilage. And the tumor is that kind of moth-eaten crap that's all in that whole neck where the other two yellow arrows are. Now, when it metastasizes to other bones. So it's a sarcoma, it's malignant, and it's quite nasty, actually. So what do? They do chemotherapy, radiation. They do immune therapy, but really it's it's this translocation that's causing it. Sometimes they even do amputations for it. So extremely malignant, high frequency of metastasis, and there's lots of reoccurrence. It's because the reason that it happened in the first place doesn't go away. Now, when I was in school, this was considered an extremely poor prognosis. We're talking less than 5% had a 5-year survival rate. It's got a lot better now, and it's saying in the book that now the survival rate is in excess of 70% if they catch it before there's metastasis. They're just way better at immunotherapy and at keeping this under control. We're better at immunotherapy for everything than we were 25 or 30 years ago. So really, long-term survival depends on metastasis rather than the tumor itself in this one. So a giant cell tumor osteoclastoma uh, is really um, the result of a malignancy in the osteoclast. And osteoclasts obviously eat bone, so this is a lytic lesion. Um, Usually found in the epiphysis of long bones, usually in the knees, but it can be in the wrist, in the arm, in the forearm, in the pelvis, can be a lot of places. So these osteoclasts really um, they grow very quickly, and what ends up happening is they don't undergo. My understanding is they undergo mitosis, but they don't undergo cytokinesis. Um, so these cells get really, really big, and they're multinucleated, um, and and they're derived from osteoclasts. So um, you can see in this MRI image of one how destructive a lesion they are. Like there's really hardly any bone left here. This looks like it's a distal femur. You can see the patella here, and you can see the epicondyles here and here, and the condyles here and here. So, yeah, this one looks like a nasty lesion. Now, it comes a little bit later, and it's one of the few bone cancers that actually is more predominant in women than in men. Um, Pretty rare. We don't see it often, uh, but it is quite painful. You can just imagine what that periosteum is doing and what the pain receptors are feeling, and what the possibility for pathological fracture is around it. It's one of these things. It's malignant, maybe. That's why it's an oma, so it's osteoclastoma. Uh, they don't go to malignancy very often, but they can. Um, and what they do is scrape it, or they just cut out the whole tumor and hope that the bone heals. If they do metastasize, it's probably going to be to lung. Multiple myeloma is um, is a bone tumor of the hematopoietic cells. So where you get it is any place where you have a lot of red bone marrow. So it's in the skull, in the pelvis, in the proximal humerus, in the proximal femur. Uh, it's it's where you find it. In the spine, and if it happens in the spine, there tends to be more pain involved because there's much more neurological kind of involvement from there. And it's multiple because what happens is you get these multiple punched out lesions. You can see it all over this guy's skull. All these lesions are all in the red bone marrow. It causes deep, achy pain, and it's found in older adults. This is not a middle-aged or a children's disease. Prognosis, really bad. It's most people die in a year or two after the diagnosis is made, because it's in so many multiple sites and it causes so many issues that it's just in immune problems and in anemia problems, in weakness in bone. Like it's just, you kind of almost name it and it's a problem. I've lumped the last ones together because they are all benign tumors of cartilaginous origin: chondroma, enchondroma, and osteochondroma. Now, this particular picture is of an osteochondroma, and basically these are like little warts on the bone. Now, there's another one called osteoma that is strictly bone. It looks like a bone spur, um, but it happens for reasons other than what bone spurs have. But I've left it out mostly because chondromas and enchondromas, osteochondroma, and actually osteochondroma is the most common of these primary benign tumors. Um, so chondroma is one of cartilage, enchondroma is when the cartilage ends up invading into the bone, and osteochondroma is this kind of like bump on the bone. It's almost like a wart that has osseous tissue and a cap uh, cartilaginous tissue. If you Google image this, there's some rather gross ones of surgeries to remove these things, and you can see the little cap of cartilage on it. They tend to grow someplace close to the epiphyseal plate, and they somewhat grow along the lines that the muscles go in the pull. So they look a lot like spurs. Um, it probably has got something to do, so it's young people, and it's probably got something to do with kind of stresses at growth plates, maybe injuries. Like it becomes a very near thing to myositis ossificans, the kind of the whole heterotopic ossification sort of thing. I've not seen any kind of adequate explanations as to the cause. They're not particularly painful unless they start pushing on something. If they push on a nerve, or they push, if they're rubbing, if you get one in a place where, like, say your shoe rubs or something, then that's when they become painful. But in and of themselves, they're not painful. It's just this abnormal growth of bone with cartilage on the end. Now, the Physiopedia website will look at all of these things, and so this particular X-ray came from that website that I have listed, and it's definitely worth a look.